I want to show you a little movie now, and in this film we're going to look at a skeletal representation of what occurs during subacromial impingement, and this will give you a little view, a little bit of understanding of the mechanics of how impingement occurs and how the structures thicken to create reduced subacromial space. As we can see here in this skeletal movie, this little video clip is going to show us microtraumas to the supraspinatus. In this case, it's going to be from overhead sports, but it doesn't necessarily refer just to overhead sports. Many times we can see there are other causes of impingement syndrome, but I do want you to see this video just so you get the concept of where the problem is occurring. So I'm going to run this, and the skeleton is going to go into a windup of a baseball pitch and throw. And you can see here that the repetitive microtrauma caused thickening of the supraspinatus, and notice how the space is reduced. Let's run that one more time. Just let's have you see that guy. You guys see that one more time. Pay particular attention to the end of the movie. Notice that the supraspinatus begins to thicken, the subacromial space is reduced, and the patient develops subacromial pain. As we move on and the patient improves, they get into the subacute phase, and in the subacute phase, we continue to consider the resting position. We progress their flexibility now to long lever stretches. The flexibility program now begins to incorporate things like using canes to mobilize them into external rotation or mobilization into abduction, and we'll demonstrate some of those cane stretches in just a few minutes. Strengthening programs can be considered at this point, and postural exercises are always considered, as they are when we look at the impingement patient. So it might be reasonable to begin to incorporate postural extension or postural retraining exercises, as we discussed previously. And as we look at this film now, we're going to look at a short film clip again of a joint mobilization technique. So our patient has progressed now from the acute phase to the subacute phase, and it becomes appropriate for more aggressive mobilization techniques. Let's look at this on the model, and we can see here AP oscillations. These are fairly significant AP oscillations, and we can see that demonstrated in this clinical video. As we see here now, we see a more aggressive anterior and posterior movement. This is again another appropriate technique, and we can see a different clinical hand placement in this mobilization technique. So these are just some examples of mobilization techniques that can be implemented in the management of the adhesive capsulitis patient. Now, as we look at the static posture, we see another static position of a mobilization technique that can be used again in the more advanced patient. This patient's clearly out at 90 degrees of abduction, once again indicating that their capsular pattern is improving, and they are able to move to they're able to move through a significant arc of motion. So as the patient improves, your mobilization can also your mobilization techniques and accessory movements will have to reflect the changes that are happening at the glenohumeral joint.